Thank you all for joining. This year has been a pretty interesting year. Rapid advances both in the drugs and in the policy framework in which those drugs are reviewed, developments on diagnostics, their tools, and their coverage. So we have had a FDA approval of a second disease-modifying drug, and on the path potentially to a third approval in the first quarter of next year. So that is all exciting. Those drugs are of significant clinical benefit and help to patients, but they are difficult. They are difficult to get on. They're difficult to be diagnosed, and so we're going to review in this webinar the milestones to understand the current landscape of Alzheimer's treatments, diagnostics, coverage, and the challenges presented by this changed environment, even as it is improving for patients. Then we're going to discuss, in the context of innovation and progress, how the community can stay comprehensive, can stay vigilant and active in advocating for fair, equitable, and comprehensive treatment and coverage. So join experts Candace Demetrius, Doreen Marks, and myself for a conversation that informs and empowers. Welcome to everybody. We're excited to have you all join us. First, for those who are not familiar, Voices of Alzheimer's launched last year, actually last fall, a little over a year ago, with the goal of empowering people living with or at risk of the disease and their family caregivers for a risk of Alzheimer's and other cognitive illnesses. United by urgency, passion to drive equitable access in innovation and treatment and care. We aim to create a society that respects the voices and choices of people living with Alzheimer's and other cognitive illnesses and managing their own health and well-being. My name is George Vredenberg. I'm a board member of Voices of Alzheimer's, also the chairman and co-founder of Us Against Alzheimer's. I'm excited to be with you today to discuss all this. We'll have 15 to 20 minutes at the end of this webinar for audience Q&A, but please feel empowered to, throughout the duration of this meeting, submit questions for our discussion by opening the chat window, and I'll keep monitoring the chat window. If you have trouble sharing your question or any technical issues, reach out to our hosts, Evelyn or Kim, by clicking on their names in the chat function. We're recording the session and posting it on our website, voicesofad.com, if you would like to share it or listen to parts of it again. If you aren't already a member of Voices of Alzheimer's, you can sign up on our website as well, and I would encourage you to do it to support this effort. Now the program. We are reviewing the developments this year to understand the current landscape, including areas of ongoing need. We're also looking ahead to what to expect in 2024 and in coming years, and most importantly, how this community, the Alzheimer's community, the patient family care community, can stay active in advocating for fair, equitable, and comprehensive treatment and coverage, and continue to have the impact that it has already had in 2023. I'm going to let the speakers introduce themselves to you, who are joined by Candace, and who's the Policy Director, Partnership to Fight Chronic Disease, as well as Doreen Monks, an Alzheimer's advocate and Voices of Alzheimer's champion. Candace, can we start with you? Could you just introduce yourself and tell us a bit about your background?
Sure. Good afternoon, and thank you so much for including me in this important discussion. As you mentioned, I serve as the policy director for an organization called the Partnership to Fight Chronic Disease. As the name implies, it is not an Alzheimer's or dementia-specific organization, but we are a nonprofit organization focused on lowering the burden of chronic diseases, including Alzheimer's disease in America. And that can include diabetes, Alzheimer's disease, any number of different conditions. And we do that by working to empower people with education, information, and most importantly, access, and working on improving access to preventive care and treatments, as well as supporting innovation to address unmet medical needs. A lot of that focus around Alzheimer's disease touches on all of those, the prevention aspect, the access to treatments, and also the innovations that we're seeing. And also wanted to mention on a personal note, until my mother-in-law passed this summer from dementia, I also helped with her care. So this is a personal passion for me as well as a professional one. So thank you again for having me.
Thanks, Candace. You have an important organization, an important role in that organization, and we're really glad to have you. Doreen, a little about yourself and your background.
So hello, everyone, and happy afternoon, and thank you for joining. My name is Doreen Monks. I'm a retired neuroscience nurse practitioner. I was the program director for the Stroke Center at St. Barnabas in Livingston, New Jersey, a program actually I'm proud to say I developed. When I was 62 years old, I was diagnosed with early onset Alzheimer's disease, and subsequent to that, I retired from work. I've spent the last 8 years as an advocate on behalf of all those living with the disease, and I strongly embrace my role as a speaker for those who cannot speak for themselves. I volunteer to multiple organizations. The Alzheimer's associations have actually done quite a bit of work with us against Alzheimer's, and other community education. So between advocates, the role as advocate and educator, I'm doing my best to preach the good word for support and progress in the treatment of Alzheimer's and other related dementias.
Well, Doreen, we're glad to have you. Your voice is important. There's something strong in the moral quality of people living with this disease that has a greater standing and greater voice and greater impact and power than virtually any other player in the Alzheimer's field. So thank you for doing what you do, and thank you for being with us. Candace, could you just walk us through the major developments in Alzheimer's treatment and diagnosis this year, and what do you think are important about those developments?
Happy to do that. And as you mentioned in your intro, it's been a tremendously important year with a lot of movement. Not quick enough, let's be honest, and I'll talk about that a little bit, but great to see the advances, particularly in treatment. We've also seen some movement on areas related to Medicare coverage and access for people living with Alzheimer's disease and mild cognitive impairment. So I want to talk about that a little bit as well. So starting with the advances in treatment, in January, so almost a year ago, the Food and Drug Administration, or FDA, and as you may recall, that's the agency that has the authority to determine if drugs are safe and effective enough to be available to us as consumers with a prescription. So they took a look and granted accelerated approval to a drug called lecanemab. It is the second such drug approved that removes amyloid plaques in the brain in people with mild cognitive impairment and early Alzheimer's disease. Accelerated approval, it's important to know, that is full FDA approval. So they satisfied the safety hurdles and effectiveness hurdles that the FDA sets in place and is the gold standard for the world. But accelerated approval just looks at a different point in time in terms of effectiveness. And this was based on whether plaques were actually removed, while the clinical trials continued to show that removing those plaques actually did impact the progression of the disease. Did it delay further progression or not? And that answer came later, and we got traditional FDA approval of lecanemab in July. I'm going to, unfortunately, in that time frame between January and July, Medicare, because they had passed a policy that they had set in place in April of 2022, they said only access for accelerated approval Alzheimer's treatments and this specific type of treatment would be limited to clinical trial participants only. Medicare already limits coverage to Aduhelm, which was another drug that was approved, to clinical trials only. Basically, that means because there weren't clinical trials available, there was no Medicare coverage during that time frame at all. Advocates, many people I'm sure on this call, reached out to Medicare to ask them to reconsider that decision, but they refused. So in that gap of time between January and July, people just did not have Medicare coverage to those medicines. In contrast, in March, the Veterans Administration, which provides coverage for millions of American veterans, announced that it would cover lecanemab for veterans. So they had coverage starting in March. As I mentioned, in July, the FDA did provide traditional approval to lecanemab, and Medicare then expanded coverage to registry participants. And that means your doctor has to sign you up in an approved registry that will track your progression with the treatment over a 2-year time period. So that does mean that there is Medicare coverage now. Still some access barriers, and we'll talk about that in a little bit. I also wanted to mention in May, the FDA granted approval to the first drug to ever treat agitation in people with Alzheimer's disease. So specific to Alzheimer's disease, and we know how agitation can be a huge issue with Alzheimer's and other dementia. So that was quite a breakthrough as well. On the diagnosis front, Medicare had limited access, limited coverage, and therefore access to PET scans, which is a type of, scan you can do that will look in the brain. It's kind of like a fancy X-ray, if you will. It's much more sophisticated than that, but just think of it that way, or an MRI, if you're familiar with those. It's a type of scan that you can do. But they had limited coverage to those under Medicare to 1 per lifetime, and only if you were participating in a clinical trial. And that had been in place for 10 years. That has changed this year, fortunately. This fall, they retired that decision. So PET scans are now covered under Medicare for Alzheimer's disease, which should open up diagnosis as well for people. We're also hearing more and more this year around the potential for blood-based biomarkers for Alzheimer's disease. Eventually, that could result in blood tests that help to identify people with what they call biomarkers, or things that they can detect in the blood. Maybe it's amyloid plaque presence or other things that would indicate more follow-up is needed to see if Alzheimer's disease is present. Those will vary. I understand that there's a lot of excitement about that, but not necessarily, they may not be quite ready at this stage, but that's another one to watch. Lastly, I wanted to mention that there is a new model of care. Medicare is announced this year, and they will cover, called the Guiding and Improved Dementia Experience, or GUIDE model. This will provide, and most importantly, pay providers to help provide this assistance. It provides a comprehensive and standardized set of services for Medicare beneficiaries living with dementia, and their unpaid caregivers are a part of this program as well. That will include coordination, because as you know, you're seeing multiple providers, help coordinating that, paying providers to help coordinate, and then also providing supports for caregivers, training, resources. Where do I go for help? 24-hour support line and the like. So a major goal of this, of course, is to help people stay at home and as long as possible, if not completely possible, and to help provide those critical supports that patients and their unpaid caregivers need. So a lot of advances, George. Sorry that took a while, but it's great to have a lot of good news to report.
No, that was comprehensive, Candace, and very effective. I'm going to turn a second to Doreen. I may come back to you about some of the developments that you described there, Candace, but I'm going to turn now to Doreen and ask Doreen, what impact will these developments have on individuals with Alzheimer's and their families, from your own experience or from what you're hearing from others that are experiencing this disease? How do you react to these developments? Positive, negative, hopeless, hopeful? What do you think?
Very much hopeful. None of us living with the disease thinks this is nirvana, but for the first time, when you looked down the road and as far as treatment was concerned, it was a black hole, and now there's a glimmering ray of hope, and there's a little light coming through that black hole, and it's exciting. It's exciting times. For the first, and not only that, to me, the existence of a drug is extraordinarily exciting, but it heralds an even more exciting point, that there now is a focus on this disease, where before there was none. I tell this story all the time. When I graduated nursing school in 1975, there were 3 antihypertensive drugs. 3. Now there are 5 classifications, and probably 4 or 5 drugs under each classification. And these drugs today would not exist without those first 3. And this is where we're at, as far as treatment is concerned. So the hope for the future is extraordinary. And it, again, nobody's thinking that taking lecanemab or any of the other drugs is going to cure everything. But every moment of time, I'm a single person. I hold on to my independence strongly. And if it's another 6 months, it's another year of independence. To me, that's an extraordinary gift. The other thing that is so exciting, and I think I spend a lot of time talking about early diagnosis and, embracing the fact that there's an issue that you need to look at. But before that was, so what? I recognize I have a cognitive issue, but what do I do about it? Well, now there are things to do about it. We're spending a lot of time in the community talking to primary healthcare physicians and being able to confidently recognize early symptoms of mild cognitive impairment. And yes, now we have access to not only the amyloid PET scans, but there's other PET scans coming down the road, tau PET scans, and other ways to do imaging of the brain. Plus the existence of this very close to the surface blood test, because other than having the PET scan, if you don't have access to a PET scan right now, the only way to measure the levels of amyloid or tau in your brain is by doing a spinal tap, where they withdraw spinal fluid and measure it. But now that's still done, but very shortly there's going to be that access. And the other thing that I'm excited about is, for too long, Alzheimer's was deep into the corner of the room, never recognized, never spoken about. And we're slowly getting pulled out of the corner and into the forefront. So, there's a lot of work that needs to be done with that. But I think that, going out to speak to people with the disease, or people who are caring for someone with the disease, I can say now, that this is not a run and hide from a disease anymore. This is a look it right straight in the face, and we're going to take care. We're going to get things done. Poor Alois Alzheimer, 1906, worked his little tail off to figure this out. And I hope he's in heaven saying, thank you, Lord, finally. But it's extraordinary times. And for the first time, I think, not just myself, but other people with the disease can say, okay, it's not great, but it's not as bad as it was. So there's just this little bit of hope that I can hold on to and watch the progression. Because as George said, donanemab is hopefully going to FDA approval in early 2024. I know that there are other studies going on that will be releasing their data, hopefully in 2024. The existence of blood tests with not only for amyloid and tau, but for other unknown, we talk about amyloid as being the biomarker for Alzheimer's, but out there are 100 other biomarkers that we don't even know about. And that's the other exciting time. So for the first time, Alzheimer's is coming out of the corner. It's coming into the forefront. People are able, I can look people straight in the eye and say, don't run and hide. There's hope on the horizon. And that to me is the best thing.
Doreen, you are exhibit A, certainly in this conversation, but in so many conversations, that a person's diagnosis with Alzheimer's is not the end.
No, and that's
you
really
have energy,
important.
You have vigor, you have a voice, you're having impact. So describe what your feeling was when you got the diagnosis. How were you diagnosed? And then
well, it's actually an interesting story. As the program director for the stroke center, of course, we had a medical director who was a neurologist and who also was an extraordinary good friend. And one day in October, Thursday in October of 2015, actually, not that I don't remember, she walked across the hall from me and knocked on my door and said, "We have to talk." Closed the door and sat down. And I'm thinking all kinds of things, nothing to do with the conversation we had. And she basically said to me, "Something's going on with you and we need to get it checked out." And that was like my world stopped at that very moment, because I knew what she meant. She wasn't just calling and say, you did something wrong. I knew what she was talking about, because she went on for more detail. Excuse me. And I'm a nurse, so nurses like to fix things, so I took a moment. I just took a moment, but I just felt I had to move. I had to do something. So I literally was on the phone to my primary care doctor. That was a Thursday. On Monday, I saw her. In 2 weeks, I had an MRI and my first of 4 neuropsych testings. Now it went on, unfortunately. So at that point, I was diagnosed with some form of dementia. They didn't know what. It took another 13 months to finally get the actual diagnosis of early onset Alzheimer's. And I don't know. I know for a moment, I had a little bit of, a moment of self-pity and, oh my God, and what am I going to do? And this is awful. Oh my God, I live alone. I'm going to die. This is awful, but I've quickly realized that's just not me. So I can only wallow for a very short period of time. And I'll wait. I decided, well, I could either wait for the archangels to come or do something. And I did something. So first of all, I did, I thought, well, I have to figure this out. And I have to plan for the end. So if I plan for the end, I got all this other time left. I can do what I want to do. And to me, I was given a gift of a very, very early diagnosis. And I guess intellectually, my brain was working extremely well. So I wanted to use that gift to say, let's go out and figure this out together. And to your point, George, I tell everybody, listen, this is still a fatal disease. It's the only chronic disease, but it is a chronic disease which has no cure. But it is not a death sentence. I mean, I'm more affected by being 70 and having rheumatoid arthritis than I am really, really significantly from the Alzheimer's. And now I guess I'm not the ordinary person, 8 years out of diagnosis, but I want people to have the hope that they can have a good and happy life. It's not the life you're planning. I was dying at my desk, this was like, I don't know what to do. And a whole lot has happened, over the course of the 8 years. And it does take a lot from you. But to me, in order to survive this and to do it, in a positive way, I had to find a new avenue. And to me, my feeling was, if Alzheimer's was pushing me, I was pushing it back, and I tell other people, I don't live with Alzheimer's. Alzheimer's lives with me. Never got invited. I don't know how he showed up. But nonetheless, I drag them along with all the other chronic things I deal with, and to me, that's what I want other people to know, that, very much like, like having heart disease and having diabetes. You get a diagnosis of diabetes. You don't completely say, oh my God, I'm going to drop dead. You say, okay, and you have a choice to manage it and not manage it. And to me, that's what I do. I manage my Alzheimer's disease much like I manage all the other comorbidities I have.
Well, it is quite striking. You talked about something that's 8 to 10 years ago, and you are clearly articulate. Your mind's working, and there's plenty of life left in you. And you got this unwanted roommate, but nevertheless, you've got them in the corner now.
Him, I got in the corner. That's right. Al's in the corner. Yeah.
So, Candace, let's look forward a little. So Doreen sort of made reference to, there are more drugs in the pipeline. People report out in 2024. You mentioned the same thing. What do you see as the developments going? What are the immediate challenges, and what are the developments going forward that gives us sort of an agenda of what the patient community really should be focused on in the next year or two?
Sure. No, thanks for that. And I think there's more ahead. So to Doreen's point, there's hope. And there's opportunity for the community to engage. So early next year, we're anticipating the FDA review and we hope approval of an exciting new amyloid plaque removing treatment. And that should come early next year. That drug, unfortunately, will be subject to the same coverage limitations under Medicare, unless Medicare reconsiders their policy. Medicare has promised to consider new data as it comes forward and reconsider. So it will be up to us and the community and advocates to hold them to that promise. So it'll be interesting to see, and it's still exciting. It'll also be important. We're collecting information now that the coverage has opened up some for lecanemab and the PET scans later this year and mid-year. So it'll be really interesting to see and important to see how is that access working? Are people, what problems are they encountering? Because nothing, brand new is easy to roll out. But is that access easing? Is coverage there? Are providers being reimbursed? Are they getting the information they need to know to move forward with the patients who do qualify for these treatments? And that will be critically important in 2024 and the year that follows will be important to gather that information and to share it with policymakers. There's also, as I mentioned, there's a lot of work being done about blood biomarkers. Anticipate hearing a lot more about that in the coming years. Information needed in earlier stages obviously gives people more opportunity. Like Doreen mentioned, she got diagnosed very early. That gives a lot more opportunity to anticipate, what do I need? What are some clinical trials that may be available and open to me that I may want to consider? We do know that there is a lot of clinical trials that have been announced for 2024 that will be enrolling. So that's definitely something to take a look at. There is a website called clinicaltrials.gov that has all that information. It is a government-run website, so that might be an opportunity to look there if you are interested in clinical trials. We are also seeing, as Doreen mentioned, because there's been some success finally in this space, there's a lot more attention being drawn to it and a lot more interest in research. The pipeline currently has 80% of the treatments in the pipeline are targeting to disease progression. And that, as we know, is critically important. How can we interrupt that progression of disease? And just like with cancer, it's important to realize, because sometimes you hear naysayers saying, well, it's just 6 months, or it's just, the delays aren't that impressive. For someone, living with an illness or caring for someone with that illness, 6 months is a lifetime for many people. But beyond that, with the pipeline being so robust, with our knowledge gaining, that gives people 6 more months for something else to come out that may be better, that may extend it for 12 months or 18 months or longer. And that progress enables those people, and that delay in progression enables those people to also benefit. We've seen it with cancer. I'm not quite sure why that same dialogue isn't happening with Alzheimer's disease, and we can speculate as to that, but delays are important to people and to the opportunity to eventually get to a cure. Coverage policies are also going to be important in 2024, and drivers how much will that attention and investment continue if coverage is so limited? So those will be really important. The only other thing I would flag, and if you're not aware, you will be very soon, we're headed into a major election year, an election cycle. I know Voices of Alzheimer's has done some great work around polling about voters care about these issues. They care about Alzheimer's disease. Virtually every family in America is touched by Alzheimer's disease or dementia. So making sure that people running for office are aware of the challenges and struggles that people living with Alzheimer's disease face will be important. And it's an opportunity in 2024 to raise that.
You're making an important point. The polling that we did actually showed that 50% of the likely voters in 2024 will say that they've had this disease in their family or the close friend. So that's about 85 million people. So it's half of America have seen this disease up close and personal, and it's a vital thing. Question in the chat, which is an interesting one, and Doreen's experience might have been relevant a few years ago when she first got diagnosed. Before 65, you're not Medicare's coverage policy. It's not irrelevant, but in fact, you're usually typically covered by a commercial insurer. So what are commercial insurers doing with respect to covering a PET scan or of this drug in populations earlier than 65? Do you, Candace?
I can only tell you my experience.
Okay.
I wasn't 65. Social Security considers early onset Alzheimer's disease a catastrophic illness. And because of that, there's an expedited approval. I actually got my Social Security approved like in 2 weeks. That's extraordinary.
Wow.
But and I'm going to ask Candace for clarification. But what my understanding is that private insurance, for the most part, follows the directive of Medicare. Now, I don't know, I can't speak to individual carriers, but I've heard, from other people that their private insurances are starting to look at, approving the at least the amyloid PET scan as a diagnostic tool. But yeah,
Sure.
it's very different, especially now because we're seeing this onset of the disease actually younger. We're seeing 40-year-olds and 50-year-olds now getting this disease. So it's imperative that we have the private insurers match, it certainly would be nice if they exceeded it, but it's certainly at least match, Medicare's, approval.
And I can speak to that a little bit more, George. The Medicare's decision to subject these medications to what they call coverage with evidence development. Basically, it's saying we don't have enough data to determine if we're going to cover it. So we're just going to cover it in these circumstances where people are participating in a clinical study so we can gather more information. So it's conditional coverage. You have to participate in a study to be covered. Typically, private plans do watch Medicare, and Medicare has a lot of influence, but for them to not cover an FDA-approved medicine for its intended use in a private health plan is pretty unheard of. That's a little unusual. They'll slap on things like you must have prior authorization or you must jump through these hoops, but just to say we're not covering it is unusual. That is not unusual, however, when Medicare requires this coverage with evidence development. And unfortunately, that's what we're seeing. A number of large health plans, private health plans, employer health plans have announced that they are not going to cover lecanemab because it's quote unquote experimental. And they're using Medicare's decision to require coverage with evidence development as the excuse for that decision. To your point about that will affect people who are younger, particularly people, Doreen mentioned that because Medicare covers people with disabilities, which includes serious illnesses like Alzheimer's disease, they can get Medicare coverage eventually, but that is a process, 2 weeks. I don't know what angels were on your side there, but that's
I don't either. I just was like, it was interesting. I left the office and by the time I got home, I got a email from them asking me for some paperwork, and I thought it was a joke. But yeah, it went very quickly.
Remarkable. That's remarkable. But for most people, there is a delay there, and we talked about delay is the enemy of the good here, because
they work very hard to not cover you. So yeah, a lot of people have to go, even with Alzheimer's, they have to go through the appeal process. Many people get to, with Medicare disability, you get denied like just Social Security disability. I mean, you get denied just off the bat, and then you have to work at getting it approved. So we'll see.
Doreen, I come back to you a second. A couple people in the chat have said that they have Alzheimer's in their family and are wondering whether they should get a new blood test or be tested for Alzheimer's or not. And I know that people react to this differently. Why should I get, detected or diagnosed with Alzheimer's if the only drug available has got this kind of duration, only has this benefit, it's hard to get on, hard to stay on because it's an infusion product right now. And others say, I really want to know. There's something about knowing that is comforting. So how did you react? I mean, you sort of
my personal opinion, because it's not that I would want, and now that I do know, obviously, but it's important to recognize your increased risk. First of all, to be, mindful of your, any issues you're having. But the most important thing I think about knowing that you have it or at higher risk, because it's not just about the meds. We know clearly, the science shows that healthy lifestyle changes, keeping your brain active, cutting, not smoking, walking, eating healthy, losing weight if you can. I am healthier at 70 than I was when I was 60, because, and to me, your brain will work. The harder you make your brain work, the healthier it will be. Very much like below your neck, what you do for your below your neck, you do for above your neck. So knowing that you're at a higher risk means you have to be even more mindful of those things, because there are other things. It's not just about the drug. The drug is there, obviously, but it's like if you have diabetes and you eat cake for breakfast and you have potato chips for lunch and you take your pill, well, that's not really helping. It's not going to work. The pill's not going to work because you're just banging against it. The same thing with Alzheimer's. The more you can do for yourself, I realized quickly I have to take responsibility for me, and I have a certain responsibility towards this disease. And I think that if you are possibly at risk because you have a familial tendency towards the disease, you just need to be even that more watchful of the not only the environmental risk factors, of which there are multiple, but also changes that you're seeing. And if you are made aware of it, it just gives you more time not only to seek out good care, because that your healthcare team is like ultimately the most important relationship you'll have in this disease, but also planning things. To me, I'm a single nurse, so I have to know everything about what, like, I can't stand anybody knowing something about me that I don't know. And so I was grateful for the opportunity to plan out certain stages basically of my life, not knowing how I'm going to progress through the disease, but making a will and getting a power of attorney, getting a healthcare proxy, and all those things I got the opportunity to do because I was diagnosed so early. So I think, maybe 10 years ago, and if there was a test and said you have Alzheimer's disease, but good luck to you, which is unfortunately the way it was always addressed. You have Alzheimer's disease, get your affairs in order, and I'll see you next visit. But now you have the opportunity to jump aboard this train of diagnosis and treatment, that you will miss if you aren't mindful of the presence of the disease.
So Candace, I'm going to come back to you a second and say, looking forward and think you're speaking now on behalf of or for a broad patient community. What should we be focusing on in 24 and 25 that is most significant? For example, we know that Leqembi is now undertaking studies to determine whether or not their infusion product can be actually administered through an auto injector. That would make it easier to get on the drug. Are there other things that we should be doing and speaking to industry on how to lower the cost or the barriers of getting onto the drug, of staying on the drug? What should we be urging industry to do? What should we be urging policymakers to do to make the future drugs lower cost, easier to administer, more powerful, more safe? What do you think the community ought to be doing and focusing on?
Well, that's a pretty broad remit, but I'll try to address it. One is absolutely working with industry to let them know the challenges that people are facing. What is it really like? What is that process like? What is the access like to providers? We know there are a lot of shortages, for example. Is there a way that we can build in more primary care related access, with screening, with, other things, referring people, talking to people about dementia and Alzheimer's disease that will help them, kind of move that process forward as we get more opportunities for prevention, as the lifestyle management issues that Doreen was speaking about, and then diagnosis and treatment. Getting people in there earlier will help us improve outcomes. So anything that we can do there. You mentioned access in terms of, we know that I think it's 1 in 5 older Americans lives in a rural area. So an infusion-based therapy can be a real challenge, in addition to provider shortages and the like. So things that we can do to make administration easier and not require a drive to the doctor's office every few weeks, or, even if it's every few months, that can create reduce the barriers, if you will, to access. That will be really important. The other thing I would just say is for people not to underestimate the power you have to influence the people who represent you. If you're having a challenge with access, it's 3 people in Congress represent you, 2 senators and 1 representative. That's 3 phone calls or 3 emails, and just checking in with them regularly and saying something like, hey, I'm concerned about the way Medicare is limiting access to Alzheimer's disease therapies. What are you doing about it? That's 3 phone calls or 3 emails that'll make a huge difference. I know they represent a lot of people, but they don't hear from them that often. So hearing from people regularly will make an impact. And so, there are simple things like that we can do. They're getting involved in the clinical trials, getting involved in the clinical trial design, any number of different opportunities depending on where people want to be.
Let me ask Doreen, from your perspective, what would you like to see our community be active on in the next 12 to 24 months?
One of my favorite role in the work that I'm doing now is as an advocate, and I have indeed visited my congresswoman more often than she probably wants me to, but I've developed a relationship with her staff, both in the local area in New Jersey and as well as Washington. Every year I go to the forum, the Alzheimer's Association forum, and visit Capitol Hill. So it's the biggest issue I think we see is that people don't know about this disease. There is no, you can't drive down a road and not see a billboard for heart disease and for cancer and for a whole host of other things, but there's no public awareness. And I think there's a lack of knowledge. Sometimes it's just because they're not exposed to the disease. Sometimes they just don't want to know about the disease. And I think the more the community and the society really knows what this disease or all the dementias are, particularly Alzheimer's disease, know about this disease, they will have a voice. They will put their voice to it. Right now, they can't. You're not getting the average person in Livingston or wherever to call their congressperson, because they don't even know that it's an issue. And I think that one of the biggest things we have to do is we have to do some sort of public service and awareness to say that there is this other disease that kills more people than breast cancer and prostate cancer combined, that is out there, and it is a pandemic, and we need you to be aware of it, because if you're aware of it, it will touch you. And just nobody in this world that's not going to be somewhere, certainly as the numbers increase, if we don't do something about it. So I think that's really, really important. That we carry the good word out to the community and say, there's this disease out there that you can have a voice in caring, not only for the person who has it, not only for the person who cares for them, but the potential for further treatment and the potential finally for a cure. So I think, to me, that's the biggest, because I go out and do community education programs, and I am startled that in 2023, there are people who literally don't know anything about this dementia in totality, and certainly with Alzheimer's disease. Yeah, even, and especially if they're not, because they're not exposed to it. But I think everybody needs to be exposed to it.
Anyone who has questions, please raise your hand or put your comment in chat, because we'll have about 10 more minutes. But we'd like to hear from anyone on the phone that has either a comment or a question. But I'm going to make a comment now that consistent with what Candace and Doreen said. Working as Us Against Alzheimer's here in Washington, what you do and say to your congressmen and to your senators is making a huge difference. For two reasons. One, they respond to constituents. And when we did have this kerfuffle, more than a kerfuffle, with Medicare last year, more than a third of the members of Congress, House and Senate combined, called, wrote, or participated in hearings to try and change Medicare's posture. And they were saying they're hearing from their constituents. They're doing that for that reason. And quite frankly, since the average age of a member of Congress, Senator, or House, is about 65 now, they're experiencing this in their own families. So it's personal to them now. But the combination of hearing from constituents and experiencing this themselves has really changed the political position of the Alzheimer's community. And it is patients and families and patient advocates here in Washington, like Voices of Alzheimer's, that is making that difference. And it made a difference this year in terms of the Medicare coverage decision. I'm going to ask a real follow-up question. We've come a long way this year. We've cracked, as I like to say, we have nicked the beast, but we have not beat it. And so I would love to have you do a little crystal balling and say, by 2030, what would you like to see in terms of treatments or non-pharmacological interventions? So what the little crystal ball, not just the next year or 2 years, but 2030. What should a target be for the Alzheimer's community by 2030? What should we have achieved? So when we have this webinar in 2030, we can look back and say, remember what we said in 2023. We brought it about.
Yeah. Hopefully our crystal ball will be accurate.
So Candace, you take the first shot at that, and then we'll turn to Doreen.
Sure. So I'm doing the math in my head and what age I'll be in 2030, and so what I'd like to see personally. But yeah, it's a lot of it to me is I'd like to be popping the champagne bottles that we have this where we at least can delay onset by multiple years, that we've got a solid vaccine or vaccine candidates for protecting the brain against amyloid and tau. That would be even more of an opportunity for a victory lap. But and if we have some solid data on what we can do to prevent upfront, if it's exposure, if it's diet, if it's mental stimulation, what can we do to empower ourselves to avoid it, to prevent it with a vaccine or more vaccines or the like, and then delay it for people who've already been diagnosed with the illness.
Doreen?
I think that from my perspective, if 2030, which I will be frighteningly almost close to 80, I would like to see at that point that we are at a minimum able to halt the disease completely, not reverse it. And I don't think we'll ever be able to hopefully, maybe we will be able to, but certainly not in those 7 years, right? Be able to reverse it. But if somebody right now gave me something and said, okay, the disease will not progress any farther, I think most people will take that. The other thing is, I think we're going to get into a point where once more drugs are being FDA approved, that because of the way amyloid is developed, it's a kind of a little circle of steps of how it gets fully developed. we may see that by 2030, we are actually taking more than one drug. Much like diabetes, some people take one, some people take three, some people take two. We may see that. And so I think that, again, in order to halt the disease, as to Candace's point, the extraordinary thing that if it could happen so that quickly is that you can actually stop the disease before it actually shows clinical presence, and that would be, that lends to far better diagnostic studies and access to diagnosis. The average time, it's years that people go before they're diagnosed. To got to get an appointment right now to a true cognitive neurologist can be up to a year or more, so with frightening, so if in 2030, we should have everybody on board with early diagnosis. The primary healthcare physicians have access to cognitive neurologists. I'm on my fourth neurologist in 8 years. Now, I would walk on hot coals for the physician I have now, but it took me, some trial and error. And I'm a neuro nurse, so I know where to look and what to look for. Most people just don't know. They just pick a neurologist and hope for the best. So I think early access to identification, therefore early access to intervention, and so that by 2030, we're saying, okay, you have this problem, but right now we're going to halt it wherever it is. And I think that would be an extraordinary gift.
I think both of you came up with really terrific answers to that question. There is going to be, I think, some news today and tomorrow on the vaccine front. I have a working group that has 8 companies, 4 regulators, Medicare, scientists sitting down to try and create a program that will get us to a vaccine by 2030. So, Candace, we're going to do what you said.
How extraordinary is that? Huh?
I look forward to celebrating that.
Yes, it's like what happened to COVID. We need the same effort that they put into COVID. And we're seeing that now, so we went from a disaster that was just killing people left and right to, again, identifying, a monoclonal antibody specific for that virus. And now having not only a vaccine, but, annual vaccines, much like our flu shot, so maybe we'll get to that point. That would be extraordinary.
It would be extraordinary.
What's one more vaccine?
As we come near to the close, is that we've got to make sure that as we develop products in this space, they are sufficiently, I'm not going to say cheap, but they are lower price, they're easy to screen for, and easy to access, so that all populations, not just white upper class people living next to an academic hospital, can do that. And indeed, if you really think about the global South, that we need to be able to do this globally, because there are maybe 50 to 55 million families with this disease now. It's only about 6 million in the United States. So the United States is only about 10% of this population of the world that has Alzheimer's. And so to get something where they don't have any neurologists in most of the world, they don't have any PET scans most places in the world, and the cost of these initial drugs is out of range for the ability of governments to cover these drugs globally. So lower cost drugs, more powerful drugs, things that the world is used to. The rest of the world is used to vaccines in infectious disease. Your mention of COVID is exactly right. Most of the world had access to COVID vaccines, maybe late, maybe in a sporadic way, as opposed to the way that we had in the United States and Europe, but at least they had access to it. And so it's a situation that we have to address as patients, because we're not thinking about this just for ourselves and our families. Although that's important. But
I think you're right about the access. You can't expect. We're actually basically leaving out the two groups of people who are at higher risk, because they don't have access. You can't expect somebody with to take 2 buses to go to some center to get a medication. So I think, to your point, George and Candace, that, we need to bring this, take what we know and bring it into every community. Because, particularly in communities of color where they've had a terrible past relationship with research trials. It breaks my heart that they're being excluded because they were at higher risk for a reason. And we don't know what that reason is, and we will never know that reason until they're included in the trials.
Any closing thoughts, Candace? And Doreen, we got about a minute each for each of you to just sort of close us out here. It's been a fascinating conversation.
No, I just would thank you again for hosting this important conversation. I think the voices from the community have made a tremendous impact and will continue to, as long as we continue to be united in those conversations about the need for better access, the need for newer treatments, for newer answers, for better answers for everyone. As you mentioned, it's an issue of equity as well as great unmet needs across the whole population. But there's a lot of hope. So it's a great time to be engaged and promising as well.
Doreen, the last thoughts? You've made a lot of great points.
I want people to leave with the understanding that this is a disease that you can manage, that you can live with, and that you have every right to expect a good and happy life, with maybe some different challenges than what you were expecting. But to Candace's and George's point, there's hope on the horizon, and there's progress being made. So becoming understanding the disease, embracing whatever issues you have, and showing and giving your voice to the community and to our government to get support, and I think that will push us in a long way. As Candace said, this is actually, if it's hard to say this, but if I had to have this disease, I am grateful that I have it now, because I wasn't grateful 8 years ago because there was nothing, and now I'm getting involved in clinical trials, and I can go to my neurologist and say, okay, this is the next step. We now have things we can do, and I want people to realize that we will all work hard to get access to everyone, so that they too can feel that, about their disease.
Well, thank you both very much. As it reminds me of a phrase of a friend of mine who said, there's no such thing as an incurable disease, only a disease that hasn't been cured. And so we're on that path now. 2023 will be a signal year on the path to curing this disease. And the faster we get there, the better. Thank you both very much for a really inspiring conversation, informed and inspiring. I appreciate your time, your attention, and all of what both of you are doing every day to try and get at this disease. Thank you.
Thank you.
Thank you, George.